Thank you very much, Jose Maria and Mari, for the kind invitation to hear in this very interesting meeting. This is the first session, is implementation of HIV prevention in Europe in general. So I'm going to focus on PrEP, as Jose Maria mentioned, particularly on efficacy, toxicity, and adherence consideration, but also some generalities about HIV prevention in Europe. This is going to be the content of my talk, as I mentioned, with a specific focus on PrEP. And let's have an overview of HIV prevention in Europe. First of all, we all know that for now more than 10 years, we have universal indication for HIV treatment for everybody. So treatment as prevention is the most important prevention tool we have. But we also have, not very popular, but barrier methods. We can talk a little bit later. We have oral PrEP. We have injectable PrEP, not a lot, but we can discuss this later. We have PEP. It's still a lot of PEP, and I'm going to show you some numbers from my center, which is in the center of Barcelona in l'Eixample. We have needle exchange programs since the 80s and the 90s when intravenous drug use was a very big problem. We have circumcision, but I don't think there are a lot of people interested now in this intervention in Europe, so I'm not going to talk about this. And also, we do not have available the dapivirine ring, which is approved by WHO to be used for women at risk who are not, who do not feel comfortable with other preventive measures in Africa. And it's a non-nuke that is within this ring and can be used monthly in Africa. But however, despite universal ART and all these preventive potential tools, we're not doing very well in Europe. This is the estimation of the new infections over the years. And as you can see, both in the WHO European region and in the European Union countries, the estimations are not being reduced compared to 10 years later. So we're not doing very well despite all these preventive tools. And if we go now to PrEP specifically, this is something EX is taking really seriously. I am, apart from my husband, I'm deeply involved in EX, in the European AIDS Clinical Society, as well as Anne-Marie. And in collaboration with the European CDC, there has been a project called the EX Standard of Care. And one of the the initial most important topics to be developed was the standard of care in Europe for PrEP. This draft has been approved for the final content approximately 1 year ago, and it's now edited. It's going to be launched very soon. So that's what EX and European CDC consider are the standards that every country in Europe should apply or should comply to for pre-exposure prophylaxis. So it's something EX really taking seriously at the European level as well as ECDC. So let's take a look. This is coming from the Global PrEP Tracker from IVAC, very nice site, where you can see what is the regulatory approvals in Europe. You have the whole world. I think it's nice to have, we have Europe in the center, but we have an overview of what is going in the world. And this is the number of products approved for PrEP use, following all the regulatory requirements. So as you can see, in the most of the European countries, you have some kind of green, which is between 1 to 3 products approved for PrEP use, but you all know very well that approved is not equal to implemented. And if we go to this document published in 2024 regarding the national PrEP guidelines, as you can see, most of the Western and Central European countries, such as Spain or France or UK, we have guidelines and we have PrEP nationally funded. So everybody in Spain can, if you can have access, we can discuss later that in the implementation, it's a big issue. You can access oral PrEP for free. It's the same in France, the same in UK. But if you go to the East, you will see there are countries with guidelines, but no nationally funded. That's the case. I don't know if Milos is already here, but in Poland, you have a guideline, but it's not funded. So you have to pay for your PrEP. And then you have other countries where it's not even a guideline. It's not surprising. Hungary, for example. Well, I'm not going to talk about it. But so there are countries where you do not have even a guideline to implement PrEP. So it's really, really, really not the same at the European level. That's the reason EX and ECDC are developing or are going to launch this document of the standards of care. And so the other problem is that not every country can target or is targeting the same risk population. For example, as you can see, almost all the European countries are targeting gay men, but if you go to prisoners, people in prisons, that is an issue. It's a really high-risk population, and only 4 countries are targeting prisoners. So we are really far away to say that everything is well implemented in Europe. But I'm going to be very quick because this is for the following presentation. And then, of course, you have difficulties in many countries to implement PrEP, particularly for some groups such as undocumented migrants. So let's take a look to the initiations of PrEP in Europe. Again, it's nice to have the whole picture. So as you see, dark blue means more initiations. We have a total initiations in Europe that this is the picture for all the available PrEP products, so long-acting and oral, but essentially it's the same picture. If I just keep this for oral TDF FTC, it's the same picture because essentially all the PrEP provided in Europe is oral TDF FTC. There will be, according to this PrEP tracker that is up to December 2024, a little bit more than 1,000 tough FTC initiations and really, really very few long-acting initiations. So we know we have it, not in every country. What about the adherence? So I think this is a really important point, and we can discuss a lot about this. And what is the definition of adherence for PrEP, and what is the definition of low adherence? This is coming from our EX guidelines that have been updated the last time in November 2024, so this is very recent content. And let me tell you that just to write this sentence, it was a huge, huge and long discussion to define what is low adherence, what has a lot of consequences, because somebody coming with a risky sexual intercourse and saying it has low adherence, you have to convert that to a PEP. So it has really important implications. So for men and women who are on daily regimen, it was decided that the appropriate definition for low adherence was less than 4 pills a week, regardless of the distribution. That means that if you took PrEP from Monday to Thursday and you have not taken from Friday to Sunday, and then you have a real risky sexual intercourse on Sunday night, according to this definition, you should not perform any additional measure more than continue PrEP. We can discuss this later. And then for men on demand, because as you remember, it's not openly recommended for women, the on-demand regimen. This was also a big discussion, but finally the definition for low adherence is non-compliance to the 2-to-1 scheme. This is also something we can debate later because there are some data, some PK data suggesting that even fewer pills than this could be enough. But this can be open for the discussion later. And then the following important mention in the EX guidelines after this definition of low adherence is that any person presenting with a low PrEP adherence, according to this definition, and a condomless at-risk sexual intercourse should benefit from PEP. So that's the reason when I'm going to talk later about PrEP. PrEP is, we're prescribing in my center 2,000 PEPs per year, 2,000, okay? So we have a lot of people with a transition from PrEP to PEP, and then, of course, those who with an indication for PrEP, when they are on PEP, they can continue later as PrEP. So there's some gray zone for these two interventions, and I think it's important to talk about this later. And then, what is the definition for low adherence for injectable PrEP? This is very easy. So anybody not receiving the injection within the window of the interval, I would say that this person is not receiving the appropriate adherence to the injections. And we also have that kind of people for the treatment. We do not have long-acting PrEP in my center, at least for prevention. Let's talk a little bit about the efficacy of PrEP. So we know very well for many, many, many years, we have more than 10 years now from the PROUD and the hypergay trials, that with appropriate adherence, we can go back to the definition I just mentioned. PrEP is extremely, very high efficacy, and when the adherence is appropriate to the regimens, it is comparable for gay men and for other people, other men having sex with men, is comparable the efficacy of the on-demand regimen with the daily regimen. And we also have, following these two main trials, we also had a lot of real-world cohorts confirming the high efficacy of PrEP intervention. And then for those people, of course, adherence and efficacy are absolutely linked. If you do not have good adherence, of course, the efficacy is when it's going down. So, but for people who is challenging, who has indication to receive PrEP, and it's challenging to take every day pills. That's the reason long-acting PrEP has been developed. And then we have, you all know, the HPTN 084 and 083 with cabotegravir every 2 months, showing superiority for gay men and for cisgender women in Africa. And then very recently, you all know the trials, the Purpose 1 and 2, with twice yearly subcutaneously lenacapavir, showing in all cases, both drugs, cabotegravir, long-acting every 2 months intramuscularly, and lenacapavir subcutaneously twice yearly, were both superior to oral PrEP in all these phase 3 trials. That was particularly remarkable for women, because women in general have lower adherence than gay men to PrEP. So this superiority was more remarkable in all the trials performed with women. In particular, with lenacapavir, there were zero infections in the lenacapavir arm in cisgender women last year, published in the New England. So I would like to share some data from Spain, because we do not have a lot of efficacy, real-world efficacy from Europe. This is a study that we were thinking over the last 2 years, I would say, but it was difficult to get the funding, to check what is the characteristics of the people. There are very few, but to know what is going on with people who unfortunately get infected despite the use of PrEP. And also because the official data, unfortunately, are not very good to know what is the real incidence and prevalence of HIV infection in people receiving PrEP. So this is a study funded by the national official source, and we are, Angel is participating, I was Jose Maria, but we are coordinating. Most of the big centers of PrEP in Spain are participating, and it's an ambidextrous multi-center cohort of people who has been diagnosed with HIV in the setting of recent use of PrEP. And we are 12 centers from 4 different autonomic communities in Spain. So the estimation for PrEP use in Spain is 30,000 users. That's an estimation. And the centers included in the scope study are, the denominator of the users is 20,000. So in our study, we have 2/3 of the whole PrEP in Spain. So it's quite representative of the real situation. Why is that? Because the majority of the PrEP is provided either in Barcelona or in Madrid, and the big centers from Madrid and Barcelona are participating. So as I mentioned, the objective was to establish the incidence and prevalence of HIV in PrEP users, because to be honest, we do not have very good official data. It's not their fault. We are not providing the data, so it's difficult to have good official data in that circumstances. And also, and this is more clinical and virological, to characterize what are the clinical, immunological, and virological features of people who have been infected with HIV receiving PrEP compared to people who seroconverted not on PrEP. So these are the data of efficacy in Spain, extremely high. Of these 20,000 PrEP users, we only were able to identify less than 60 cases of seroconversion. That means that is a cumulative incidence of 0.2, so extremely efficacious. And as expected, the majority of these people who get infected in Spain reported poor adherence according to the definition of IACS, or PrEP interruptions for different reasons. And I would like to talk a little bit more, but this has been submitted to IACS, so if it is approved, you will need to wait a little bit to have more data of this study. It's going to be presented, if approved, in a couple of months. So what about the toxicity? This is coming from the CDC. It was funny for me to read that the first sentence is PrEP is considered generally safe for pregnant women or persons. That's true, but there are very few pregnant persons on PrEP. Apparently, all the rest of the groups have disappeared from the US. But if it is safe in pregnant women, of course, it is safe in everybody. That's the general consideration. And let me share my experience. Our cohort is not the biggest for PrEP in Spain. It's maybe the 4th or the 5th center. But we have 2,000 users, PrEP users. And we had approximately 20% of discontinuation, but they're mostly lost to follow-up, people who are moving to other communities. But for toxicity, we only have 2 discontinuations. So that's the overall, let's say, image of the safety of PrEP. 0.1% of discontinuation due to toxicity. We all know that the 2 main toxicities for TDF are kidney and bone concerns. So for the kidney, very quickly, that's what IACS recommend, but that's exactly in line with HESIDA guidelines. We recommend to discontinue TDF FTC if you go below 60 of estimated filtrate. Between 30 to 60, you should consider to use then TAF or cabotegravir if you have it available. Of course, lenacapavir is not mentioned because it's not even approved in the MIA. And then if you are still above 60, but you have a 20% decrease, and then also some signs of tubular dysfunction, it should be also reasonable to consider TAF or cabotegravir long-acting. In case that you have severe renal insufficiency less than 30 or some moderate to severe tubular dysfunction, then you should avoid both TDF and TAF. This is very basic, and this is coming in line with all the major international guidelines and what is written also in our national guideline in HESIDA that was published a couple of years ago. And regarding the bone density changes, most of the PrEP users are young men, so it's not the main concern. The only concern we have is for really, really young adolescents. In that case, there are studies showing that the bone mineral density can go really down and even not to recover following the interruption. So for young adolescents between 15 to 19, you should consider maybe TAF instead of TDF. These are the main concerns, but as I mentioned, with more than 2,000 users in my cohort, only 2 people having a discontinuation due to toxicity. And then this is not a side effect, but it's something that should be mentioned that you all should know that when you're providing PrEP, you may have a miss or a delayed HIV diagnosis. This is not, of course, a side effect, but something you should consider. And also you may have the risk of development of resistance. The most critical scenario for that is the Levi syndrome described in 2023 in CROI from people participating in HPTN 083. This means long-acting early viral inhibition. That means that people getting infected, it's really difficult to demonstrate the infection because they may have really, really low viral loads, even below the limit of detection, even alternating positive and negative tests, as this case showing that by Susan Eshelman in the CROI. But you can also see that with the oral PrEP. That's coming from an overview of all the trials with oral PrEP. And you may have a lower viral load peak, even undetectable at the diagnosis. We have had a couple of cases like that. A really delayed seroconversion, it could be difficult to demonstrate all the pattern in the Western blot, but even a single band. Then, of course, you never have any symptom because the viral load peak is really blunt, so you do not have any mononucleosis-like syndrome, so people are not going to seek for medical advice. And, of course, you may have, according to the circumstances of the use of the PrEP, if it was bad adherence, or if it was starting PrEP in somebody who was infected only by few days, that the risk of resistance can be really high, up to 50% of these cases. So very quickly, I'm already over time, but we have been talking, I can be a little bit longer, very quickly. So I know this is not very popular, but we're going to the fewer and fewer use of condoms, and I do think we should consider to promote a little bit more condoms and to insist whether PrEP is a complementary intervention, also for women, for young women. In France, for example, it was a recommendation from the European Union to provide for free the condoms because they had seen that the use in people between 18 to 25 was the lowest historically, with an increase in 30% of STIs. But this is, of course, not a compulsory recommendation, so there was done in France and, to my knowledge, not in any other country. And then, just a reminder, we do not have intravenous drug use in Spain or in France, or very few, but there's a lot of intravenous drug use in Eastern Europe. And as you can see, you have the countries where needle exchange have been implemented, but as you can see, it's completely flat since the 90s, and no other country, to my knowledge, is recently implementing needle exchange program, and this is very important. And just to finish, PEP, I'm not going to enter to the indications, but remember that you can consider to switch from PrEP to PEP and then to continue PrEP in somebody who has the indication for PEP. Also that U equals U is not applicable to all type of exposures. That's really important to remember. And we're moving towards STR regimens with not enhancer. We did a trial very recently with doravirine, which is an interesting drug if you have the co-formulation and low transmission of resistance to non-nukes, because it's co-formulated, very cheap, and can be also interesting. And again, as I mentioned, we had 2,000 post-exposure prophylaxis indication last year and 500 sexual assaults who also received PEP, so 2,500 over 1 year. So it's a lot of money, a lot of intervention, and something we should consider also in Europe. So just to finish now, PrEP is a highly efficacious and safe preventive measure that is well integrated in the HIV prevention in Europe, which include, as I mentioned, PrEP, PEP, needle exchange, and all the other measures, including tetanus prevention. However, we have large gaps existing between PrEP approvals and implementation with irregular availability and practices observed within Europe. Oral daily or on-demand PrEP is appropriate, to be honest, for the majority of people requiring PrEP. And TAF, FTC, or injectable PrEP are alternative for people experiencing TDF-related toxicity or contraindication or problems to complain to the oral medication. And then Cabotegravir and lenacapavir are both superior to TDF, FTC for PrEP in all the populations evaluated and overcome most of the adherence concerns. So these are, you are all in Barcelona. If you want to visit, that's my university and my hospital. And thank you very much for your attention.
Thank you.